Congenital heart disease is very important, but in the context of the big picture, it's kind of a niche. Between 25 and 32,000 children are born each year, 0.8% of all live births with congenital heart disease, and as Murray alluded, nearly 85% will live till adult life. On the other hand, between 500,000 and 600,000 Americans will drop dead during the next calendar year with acute ischemic heart disease. So we're dealing with orders of magnitude of greater volume in these patients. So let's talk about acquired heart disease for the next hour or so. The four forms of acquired heart disease we would talk about would be atherosclerotic disease, valvular disease, pericardial disease, and then cardiomyopathy. But we've already done cardiomyopathy. So let's talk about atherosclerosis and ischemic heart disease. And let's start off talking about coronary calcification. Back in about 1927, 28, it's very interesting. Rinkin discovered the X-ray in 1898. By 1903, he had won his Nobel Prize. By 1905, there was a major industry manufacturing X-ray equipment. These overachievers, you can't deal with them. By 1928, the first report of coronary artery calcification on a plain chest film was made by a German radiologist. And the association between atherosclerosis and coronary artery calcification was made. The problem was, back in the 20s and 30s, atherosclerosis was felt to be some degenerative process of aging, not associated with anything significant, because everyone was dying of infectious diseases long before they lived long enough to die of their heart disease. So this was filed and forgotten. The ability to demonstrate coronary artery calcification on a plain chest film is something of an art, because chest films are not shot for the calcium. We shoot chest films for the lungs. So seeing coronary calcification on a plain chest film is rather difficult, and we tend not to look. However, if we look at the lateral view, we can see tram track calcification generally seen around the geographic center of the heart. Remember, in the middle of the heart, that's where the aortic valve lives, and the coronary arteries come from the aortic annulus. So here's tram track calcification in the proximal portion of the lateral chest film. The tram track calcification is because we're seeing intimal calcification on side view. The atherosclerosis is a systemic disease which involves the intima. So it's the intima that thickens, and it's the intima that calcifies. So if we look in cross-section, we're going to see a circular calcification. And if we look in a longitudinal view, we're going to see tram track type calcification. This is a 35-year-old CT examination. It's a second-generation scanner. Nothing magical about CT for coronary calcification. CT is exquisitely sensitive to detect calcification, and we can see this is anterior descending artery calcification, calcification extending from the posterior left sinus behind the right ventricular outflow over the top of the interventricular septum. The presence of coronary artery calcification is an exquisitely sensitive and accurate indicator of the presence of coronary atherosclerosis. The problem is it's not clear the significance of this finding. The real issue is the arterial wall and acute coronary occlusion. This is a left coronary arteriogram in the RAO and the LAO view. Catheter comes retrograde around the aortic arch. We're injecting into the left main coronary artery. And here we can see the left main coronary artery, the circumflex artery, and marginal branches, and what looks like probably the anterior descending artery with some stenoses in its course. If we turn this patient into an LAO view, 90 degrees in the opposite view, here's that posterior left aortic sinus, and there's the left main coronary artery, we see that the anterior descending artery is occluded. This is a diagonal branch of the anterior descending artery. This lesion corresponds up to here. This is an acute coronary occlusion. Acute myocardial infarctions, we now understand, are caused by acute coronary occlusion, and the mechanism of acute coronary occlusion is acute plaque rupture. The fatty elements, the cholesterol esters within the arterial intima, within the fatty plaque itself, become exposed to circulating blood products. And this is caused by a break in the fibrous sheath that surrounds the fatty plaque. If that fibrous sheath breaks, and this is a circadian process, there are more acute myocardial infarctions between 12 and 6 o'clock in the morning than any other time of the day. If the sheath breaks, the fatty elements, the cholesterol esters, are exposed to circulating blood products, and there's a torrential thrombus formation. Even rapidly moving blood through the coronary tree can't wash this junk downstream. And these people have acute coronary occlusion. They acutely deprive myocardium downstream of oxygen, and they have a myocardial infarction. Myocytes die. The severity of the myocardial infarction relates to the proximal nature of the occlusion. A more distal occlusion subtends less myocardium, it's a less severe lesion. proximal occlusion, sometimes more myocardium, and collateralization. We understand that collaterals are you're probably born with a collateral bed. You don't generate new collaterals in the coronary tree, but rather there are circumstances where the collateral bed becomes vasodilated and vasoactive, and it has to do with endothelial function. Nevertheless, this is that same patient, and we injected the right coronary artery in this injection. This is the RAO at a later view. In this RAO view, we inject the right coronary artery, we fill the posterior descending artery, and then coming off the posterior descending artery, these fine collaterals making their way through the interventricular septum up to the anterior interventricular groove where we see the distal anterior descending artery. This is an acute coronary occlusion causing acute myocardial infarction. Let's digress for a moment and talk about non-invasive or less invasive means of looking at the coronary arteries. For the longest time, MR coronary arteriography along with MR spectroscopy were held before us as the great coming event. We're going to solve coronary disease with this technique. If every MR examination showed the left main and the anterior descending artery and all these marginal diagonal branches as well as this, that may have been the case. The fact of the matter is MR coronary arteriography is a difficult technique to perform. It's of limited accuracy because we're looking with a tomographic technique at a moving object. And if you could ever devise a less favorable organ to image, it's the heart because it beats. So we've gone through several series of changes in how we do MR coronary arteriography. This is a frame from a contrast-enhanced gradient echo acquisition in the RAO view. Here's the SVC in the right atrium, tricuspid valve, right ventricle, septum, the muscular septum and the membranous septum, left ventricular cavity, aortic valve, and there's the left main coronary artery and anterior descending artery going over the top of the interventricular septum. The first thing we recognize is that the artery is small. Only about 3 or 4 pixels subtend that artery, so our ability to judge percent stenosis is severely limited. Second of all, it's a tomographic technique. We're not imaging what's going on in front of this artery or behind this artery. So we have to take individual sections and put them together either in our mind or with a 3D reconstructor to begin to develop the arterial tree. And finally, we don't know if there's flush occlusion of side branches or the absence of a side branch because the temporal and spatial resolution is much less than the caliber of the vessels. This is a right coronary arteriogram in the LAO short axis section. Here's the anterior aortic sinus, the right coronary artery running along within the fat of the anterior AV ring. This is a fat-suppressed image, so the fat looks black. And with not too much imagination, we can begin to see marginal branches of the right coronary artery. Our ability to judge percent stenosis on MR examinations is very limited. In a review 10 years ago, Andre Durinks, and this has been revised, it's the same numbers, showed that the sensitivity and specificity of MR coronary arteriography of coronary atherosclerosis is really not so hot. And I really want to point out, for example, left main and circumflex disease. The sensitivity of coronary MR for left main stenosis, okay, is 50%. Now, if you think about that for a second, it's a coin flip. If conventional coronary arteriography had a 50% sensitivity for left main stenosis, we wouldn't be doing conventional coronary arteriography, we'd be doing something else. So it's a very limited technique. Furthermore, if we look in the posterior circulation, the circumflex, we find that the sensitivity for disease is nearly 0. Let's make it 25%, give them the benefit of the doubt. We know we have difficulty with the back wall of the heart with nuclear and other techniques, but 0% sensitivity is rather limited. And the best we're seeing is 70 to 60% sensitivity. So MR is a very limited technique, and for that reason, not a whole lot of it is being done. There are a lot of cardiologists that are writing a lot of papers about it, but it's of very little clinical significance. Which brings us to tomographic examination, CT examination of the heart. When we talk about CT of the heart, we're really talking about 2 technologies. We're talking about electron beam technology and spiral multidetector technology. Let me spend a couple of seconds just describing those for you. This is a figure from 1906, one of the first commercial X-ray tubes, and the way we generate X-rays is still basically the same way that it was 100 years ago. We accelerate electrons to an anode, and then the interaction of the electrons with the electrons of the anode. There's an exchange of energy. 98% of that energy is lost as heat, and 3 to 5% of the energy is transmitted as X-rays. The electron beam scanner produces X-rays in a similar manner, but in a dramatically different way. This is a lateral view, a longitudinal view of an electron beam scanner. The patient's lying on the table within the gantry. At the head end, there's an X-ray gun that boils off electrons. It's a cathode, just like in a normal X-ray machine. And the electrons are accelerated through an electrical field. And then at the tail end of the electrical field, they're deflected by a magnetic field. You can move the X-ray, the electrons, around the inferior aspect of the gantry by changing the magnetic field. And you can move these electrons with a magnetic field at virtually zero inertia because they're moving nearly the speed of light, and electrons have virtually no mass. So you can generate X-ray, you can generate electrons, deflect them towards the target rings below the individual, and then generate X-ray photons. We're looking now from the head end towards the feet end. Here's the patient lying on their back. This is the gantry. The electrons are generated behind us, and they're deflected down to the anode on the target ring. They interact with the anode, and X-ray photons are generated. They pass through the patient, and the detectors pick them up. We sweep around the patient this way, and we generate projections that way. Because we're dealing with an electromechanical process, this is very rapid. So we can acquire projections to generate an image slice on the order of 50 to 100 milliseconds. Okay, a conventional CT scanner we'll see is on the order of a couple of 100 milliseconds. Since we're operating at very rapid speeds, we can stop cardiac motion and acquire images of the heart. This was a tremendous breakthrough for rapid imaging. The downside of this is that we're doing it at very low radiation exposure. I can't believe I'm saying the downside is less radiation exposure. Well, for the patient, less radiation exposure is terrific. But for us as interpreting that image, it's a disaster because the radiation exposure is low, the photon flux is low, the signal-to-noise ratio is low, and image quality is deteriorated. One of the reasons these scanners never sold the way conventional scanners sold is because the quality of the imagery deteriorates dramatically as the patient weight increases. If everybody weighed 90 pounds, we get beautiful pictures off these machines. When you consider that most people with heart disease are overweight, the quality of the study deteriorates dramatically. The way the manufacturer overcomes this deterioration of image quality is by using thicker slices. And as you increase the slice thickness, you lose spatial resolution. So the compromise is between very fast, low radiation exposure and lower signal-to-noise ratio. On the other hand, spiral multidetector CT is basically just a normal portion of the evolution of conventional CT. The X-ray tube revolves around the patient. This is a fifth-generation model, so the detectors are fixed. On the fourth-generation scanner, the detectors and the X-ray device, the X-ray generator, move around the patient. As a result, we're using a conventional X-ray source, conventional X-ray tube, so radiation flux is high. Image quality is high. Since signal-to-noise ratio is very good, we can cut slices down on the order to 0.6, 1.25 millimeters. People are starting to fool around with 16 detector systems down to 0.3 millimeter thick slices. The downside of this system is you have to run the X-ray tube and the detectors around the patient, which is a lot of inertia. You can't do it very quickly. So the acquisition time is rather slow, on the order of 200, 300 milliseconds per acquisition. Therefore, if the patient's heart rate is greater than about 60 beats per minute, the acquisition time is longer than the amount of time you spend imaging at that point in the heart. So we have to come up with alternative techniques. And what we do then is we beta block the patient. We have to pharmacologically slow the patient's heart rate so that the heartbeat is slow enough that we acquire all the image data to generate projections through time and space. Let me give you a little diagram. This is the electrocardiogram, a series of R waves. And the R wave measures the beginning of electromechanical systole. So we have systole, diastole, and so forth. In an electron beam CT scanner, there's a prospective acquisition. The machine waits for finds an R wave, waits so many milliseconds, takes a picture, collects projections, waits for the next R wave, delays to the end of systole when the heart motion is stopped, takes another set of pictures, and so on. This is how you get so-called prospective acquisition, and this is how electron beam works. The multi-detector system, on the other hand, cannot prospectively acquire data because the heart is beating too quickly and the patient is moving through the scanner. So each of the 4 or 8 or 16 or 32, and buy stock in a company and go for 64 detectors, we're acquiring projection data through different portions of the cardiac cycle through each revolution. The computer keeps track of where in space and where in time with respect to the R wave this projection data is obtained, and then basically puts back the picture together, and you could do so-called retrospective reconstruction. You can acquire data throughout the cardiac cycle and then reconstruct it at any point in the cardiac cycle, or if you're interested and spending the time, you can reconstruct at multiple points through the cardiac cycle and display this data in a loop mode and thus generate a cine examination, a beating heart examination from a CT scanner. The clinical use of CT of the heart is basically for coronary calcium scoring and the growing area of CT coronary arteriography. Now, Harvey Hecht is a lipidologist. That's what a cardiologist who worries about lipid disease calls themselves nowadays. He argues that electron beam scanning are great for the identification of patients with lipid abnormalities and as a selector for patients who go on to a stress test. This has not been documented in the literature. This is an opinion. Let's talk about coronary calcium scoring for a moment. Coronary calcium is a surrogate for coronary artery narrowing. In other words, people who have the most coronary calcium have the greatest plaque quantity, okay? And the plaque quantity, the amount of atherosclerosis, the amount of atherosclerotic plaque you have, is a powerful predictor for future events. So we would expect that people who have the most coronary calcium are at the greatest risk of having significant coronary stenosis. The problem with this hypothesis is that we know that with age there is an increase in the amount of calcium in the coronary tree, in the entire arterial tree for that matter. So the coronary calcium score per se is not as important as the coronary calcium score as a function of the individual's age. A coronary calcium score of 100 in a 70-year-old is a meaningless finding. A coronary calcium score of 100 in a 20 or a 30-year-old carries profound significance. Let's look at the relationship between coronary calcium scores and stenoses, stenotic 70% lesions. Here we have a series of patients, series of articles where people did electron beam scans and they compared the incidence of 70% stenosis with the coronary calcium scores. And what we found is that the sensitivity and specificity of the technique is rather good sensitivity. In other words, if you see coronary calcification, the chance of finding coronary stenosis is rather good. But if we look at the positive predictive value of these, I draw your attention to the positive and the negative predictive value of these tests, these electron beam scans. The positive predictive value is kind of, not much better than a coin flip. In other words, the presence of coronary calcium doesn't necessarily predict significant stenosis. Okay, statistically, it infers it, but explicitly in individuals, it doesn't predict it. However, look at the negative predictive values. They're all, with one slacker in this population, they're all very high. In other words, a negative coronary calcium scan, a coronary calcium score of 0, basically imparts a 95%, gives you less than 5% chance of having coronary artery stenosis. In other words, 95% protection against coronary artery disease. If you take those 5% of patients who have 0 coronary calcium scores and have coronary disease, coronary artery disease, we find that 80% of them have one vessel coronary artery disease, which is treated medically, not surgically or by intervention. So the value of a coronary calcium score lies more in its negative predictor than in its positive predictor. Let's look at coronary angio. In other words, why deal with this surrogate? Let's look at the lumen itself. Let's decide who's got stenosis and who's got occlusion. If we think about CT coronary angio, we have a lot of issues we have to deal with. I mean, what's the accuracy of this technique? A limited number of studies have been performed. You have to know how to administer contrast. It's done basically like a CT aortogram. Heart rate control, the multi-detector scanners do not operate very well at high heart rates. You have to pharmacologically get the rate down. You have to choose the imaging field, the imaging factors, which phase of the cardiac cycle to reconstruct, how to interpret these things, how to display them, and one issue which is always lurking in the background, archival. This is a series of electron beam and multi-detector CT coronary angiogram studies where multi-detector and electron beam scans were compared with conventional coronary angios. And again, there's a lot of data here, but I draw your attention to the positive and negative predictive values out at the end. If you look at the positive predictive value, in other words, a CT coronary arteriogram, which was positive for coronary stenosis, had between a 60 and 70 or maybe 80% predictor of the presence of significant stenosis on an angiogram. Better than the coin flip, but not that great. On the other hand, if we look at the negative predictive value, if we look at patients who had no coronary stenosis and no coronary occlusion on their CT coronary arteriogram, it's a very powerful predictor of the absence of coronary artery disease. In other words, it appears that CT coronary arteriography is not going to be used so much to identify patients who need an intervention, who need to be worked up and followed, but rather it's probably going to end up being used as a technique to triage people away from the interventional lab towards more orthogonal medical type therapy and medical treatment. In other words, if a patient comes in with atypical chest pain and the CT coronary arteriogram is negative, you can feel reasonably confident that they are not having an acute coronary occlusion, they are not having an acute coronary event, and these patients can be treated medically. Can we use this to look at coronary bypass graft disease? Coronary bypass graft disease is a very important problem because these people don't get sick until the graft occludes. So we need some sort of intermediate test between acute occlusion. Can we find stenosis? So let me show you a couple of cases. This is an electron beam scan. This was obtained from an electron beam scan. This is a patient who had chest pain 8 months after his coronary bypass graft surgery. We can see the lima coming down and anastomosing onto the anterior descending artery. We can see one graft heading back towards the circumflex artery. We can see the stump of the graft which went to the occluded right coronary artery. So we can identify stenosis and occlusion in these patients. Here's another patient. This is a multi-detector scan. Here's the lima coming down onto the anterior descending artery, and here's a circumflex graft going over the top of the pulmonary artery. So we can use these as a screener to identify people whose arterial grafts are occluding. How else can we use this technique? Well, sometimes we see gaps. If we're giving contrast by intravenous route and we time this to get onto the arterial side, this is a blow-up, we can see gaps in the lumen. And these gaps in the lumen represent one of two things, either intraluminal thrombus or fatty plaques, low signal intensity fatty plaques. Here's another patient where we can see this low signal intensity filling defect along the wall. This is a fatty plaque. If we could detect fatty plaques with impunity, if the accuracy for detection of fatty plaques was high, then we would have a means of going after patients who have asymptomatic, potentially lethal cardiac disease. This is yet to be shown, and this is going to take a little bit of time. This is a case that was sent to me from San Diego by Eric Goodman, one of our former staff. In San Diego, anybody comes to the hospital with shortness of breath, they're going to get a pulmonary arteriogram, CT pulmonary arteriogram, because that's where they do all the embolectomies for pulmonary hypertension. So shortness of breath is pulmonary hypertension. It's proved otherwise. So this patient came to the hospital with shortness of breath, and this study was done in the middle of the night, and they noticed this lucency within the proximal anterior descending artery. Here's a blow-up. And the resident and Eric tried to convince the cardiologist this was a coronary stenosis, and they wouldn't hear it. They beat on them. They finally got him to take the patient to cath. And here's the coronary arteriogram, and there's the fatty plaque obstructing the proximal anterior descending artery. So the future of this technology is just that. It's the future, and it has to be proved out. But it's very hot, and it's done with CT, and we do CTs. The effect of the acute coronary occlusion is the acute myocardial infarction. And the radiographic appearance of acute myocardial infarction shows up in two basic flavors. There's the first acute myocardial infarction and subsequent acute myocardial infarctions. In the first acute myocardial infarction, this is the first serious insult to the ventricular myocardium. A piece of ventricular myocardium is rendered ischemic or dead because of the occlusion. The ventricle becomes stiff. The compliance of the ventricle becomes higher with ischemia. As left ventricular compliance decreases, left atrial pressure has to rise to maintain filling of the ventricle. Because of papillary muscle dysfunction, because papillary muscles may be rendered ischemic or myocardium adjacent to a papillary muscle is ischemic, the mitral valve doesn't function normally, and you get tremendous mitral regurgitation. This is an acute process. There isn't enough time for the left atrium and the left ventricle to dilate in face of this volume load, so we see an essentially normal-sized heart with moderate to severe pulmonary vascular congestion. In people who have had previous myocardial infarctions, long histories of ischemic heart disease, the ventricle and the atrium have dilated, and the acute insult of the acute myocardial infarction results in severe pulmonary vascular congestion in face of a large heart. So it's the acute change in the pulmonary vascular congestion that's the hallmark of the acute myocardial infarction. This is a gradient echo MR examination in a patient with acute myocardial infarction. Don't try this at home, kids. I was younger and foolish. This is a patient undergoing acute myocardial infarction. Here's the left ventricular myocardium. You can see some thinning out by the apex. During ventricular systole, we see a signal void jet extending from the mitral valve into the left atrium. That's mitral regurgitation. Notice that the left atrium isn't especially enlarged. Neither is the left ventricle in this patient. This is an acute process. This is a patient with chronic mitral stenosis, just to show you a large, chronically dilated left atrium. This is what chronic dilatation of the left atrium looks like. MR is a useful technique for looking at ischemic myocardium for a number of reasons. This is a 70-year-old having an acute myocardial infarction. This is a short-axis diastolic and systolic gradient echo acquisition. From diastole to systole, we can see that the superior portion of the interventricular septum and the posterior wall of the left ventricle is thickening more than is the inferior portion of the interventricular septum. In other words, this inferior portion of the interventricular septum is ischemic. It's not contracting normally. Now, this is an objective criteria. You could put a ruler on it and measure it, but it's really a difficult thing to believe, much less convince someone else of. So we can do other things with MR. We know that a final common pathway of a lot of cardiac disease, ischemic cardiac disease, including acute myocardial infarction and ischemia itself, is edema. Water molecules get laid down in the interstitium of the myocardium. So here's a T1 weighted, same patient, T1 weighted short axis acquisition. With a little imagination, we can say that this portion of the ventricular myocardium is slightly brighter, greater signal than this portion. Well, you're a nice audience, it's late in the day, you don't want to give you too hard a time, so you let it go. I've had a great deal of difficulty convincing others of this as well. So we can T2 weight. When we T2 weight, when we use a longer TR and a longer TE, we bring out the water molecules. Water has a very long T2 on the order of 1,000, 1,200 milliseconds. So imaging way out late, the water lights up. And we can see that the inferior and portion of the superior septum are very bright on this T2 weighted image. Look at the stomach and the spleen. Okay? This is edema. And edema within the myocardium is a good sign of ischemia. This is an ischemic left ventricular myocardium. A very important technique which has just become popular is the use of delayed hyperenhancement. This allows us to differentiate between normal and dead myocardium. This is a very important differentiation. You don't want to bypass dead myocardium. We know that normal myocardium tolerates gadolinium. Gadolinium gets injected intravenously. The gadolinium gets into the capillary base, into the capillary phase, doesn't enter the myocytes. The myocardial cell membrane excludes gadolinium. And then the contrast passes through the capillary bed to the venous side and out. In other words, it's a wash in, a wash out. If myocardium is dead, one of the earliest things to happen is that the cell membrane breaks down, and you now have communication between the interstitium and the intracellular space. The gadolinium that's given intravenously now gets into the cells, and because it's in the cells, it doesn't get washed out as rapidly. And if you image 10 minutes later, and it's not clear why it's 10 minutes, some series it's 15 or 20 minutes, this is something that has to be worked out. But if we see contrast lighting up 10 minutes after intravenous injection of contrast, that's a sign of dead myocardium. This is a very important criteria. However, we now understand that intravenous contrast will light up in other processes as well as dead myocardium. We see intravenous administration of contrast will light up arrhythmogenic RV dysplasia with its fibrous replacement of the free wall. And we see the myocardium lighting up in dilated cardiomyopathy. We think because of fibrosis, we're not really sure. So although this is exquisitely sensitive for dead myocardium, it may be more generalized than we think. The result of the acute myocardial infarction is that myocytes die. And when myocytes die, the wall gets thinner. And if the wall is thinner, it doesn't tolerate systolic pressure as well as the rest of the ventricular myocardium, and we get aneurysm formation. The plain film diagnosis of cardiac aneurysm, of myocardial aneurysm, is based on an abnormal contour of the heart border. If the myocardial infarction did not involve a heart border forming piece of ventricular myocardium, we're not going to see an abnormality of contour. Here, with a little imagination, there appears to be a bulge in the anterolateral aspect of this left ventricle. Now, it's a slide that's being projected at a great distance. With a little imagination, you might be able to pick up some calcification in there. Nevertheless, if we roll the patient into a lateral view, we can see this curvilinear calcification extending from the proximal portion of the septum all the way down towards the cardiac apex. The differential diagnosis of this kind of calcification is calcification of an anterior descending coronary artery, which runs along the top of the interventricular septum, or calcification of the interventricular septum. If it was tram track and it extended all the way back to the valve, we'd go for coronary calcification. The fact that it's not all the way back to the valve and the fact that it goes all the way down towards the apex tells us that this is calcified left ventricular myocardium in an old myocardial infarction. The natural history of left ventricular aneurysms is that about 80% of left ventricular aneurysms form after 6 years. So we have to go way out before we find some of these calcifications. Here's a patient who had an acute myocardial infarction. At this time, the ventricle was a little dilated, nothing much to write home about. But 6 years later, we can see that there's a rim-like calcification along the bulge on the anterior wall of the left ventricle. Calcification in myocardium means dead myocytes, old myocardial infarction. We have to differentiate myocardial calcification from pericardial calcification, which we'll get to in a little bit. This is a left ventriculogram in the RAO view. How we define an aneurysm is determined by the technique we use to image the aneurysm. On a plain film, we're looking for an abnormal contour caused by the bulging of the myocardium during systole. On a left ventriculogram, which is a luminogram, we're looking at the cavity of the lesion, we judge an aneurysm by the failure of the myocardium outside the cavity to shorten and make the cavity smaller. From end diastole to end systole, we can see that this portion of the ventricular myocardium is not contracting. Therefore, this portion of myocardium is the aneurysm. So it's looking at the hole instead of the donut when we look at ventriculograms. Using short axis views in MR, we can look at the left ventricular myocardium through the cardiac cycle from diastole to systole, and we can see that from diastole, the left ventricular myocardium thickens to systole, the cavity gets smaller, and this portion out here, which is subtended by myocardium which doesn't thicken, is the anterior aneurysm. So we can diagnose aneurysm by failure to thicken and by this bulging of the cavity in the wrong direction during ventricular systole. Here are two more patients with left ventricular aneurysms. Keep your eye on the ball. The problem is not that the posterior wall looks so thick, but rather the myocardium out here looks thin. You know, when we cut the heart oblique to its intrinsic axes, you can make left ventricular myocardium look thicker than it really is. But there's no way you can take normal myocardium and make it look thin. Look for thinning before you start worrying about thickening of the ventricular myocardium. This is a patient that had an old anterior descending myocardial infarction. This is a 3-year-old that has anomalous origin of the left coronary artery. The left coronary artery comes off the pulmonary artery. As a result, the left ventricular myocardium is rendered ischemic. There's mitral regurgitation, dilatation of the left atrium and the left ventricle, and this kid actually suffered an anterior myocardial infarction. We can differentiate between true aneurysms and false aneurysms only histologically. Only the pathologist can say this is a true aneurysm, this is a false aneurysm. A true aneurysm has all layers of the ventricular myocardium. There are myocytes. A false aneurysm is the result of a perforation of the heart. Therefore, the wall has no myocytes. That's a histologic diagnosis. We know that 80% of true aneurysms are anterior and 50 to 60% of false aneurysms are posterior. So a posterior aneurysm is very suspicious for a false aneurysm. Here's a patient who presented with a little bit of left ventricular enlargement, and the left ventricle is dilated back here. If we look at the previous examination from a couple of years ago, we can see that the left ventricular posterior border was much smaller. This is a posterior aneurysm of the left ventricle. This is a person who had a perforation and a pseudoaneurysm formation. Axial MR examination from diastole to systole, the left ventricular myocardium thickens, the cavity gets smaller, but this business back here doesn't change significantly in size, and look at the posterior wall. It's not changing at all. This is a pseudoaneurysm of the left ventricle. It's posterior, and the tissue, this isn't myocardium, the tissue that's surrounding this, that's containing this, is not contractile. This is fibrous stuff. This is pericardium, pleura, gunk in the pericardium and pleura. This is not myocytes. This doesn't contract. Now, we can use MR to look at perfusion of ventricular myocardium in an exactly analogous way that we use nuclear studies. Okay, we can give intravenous gadolinium, and we could follow it through the ventricular myocardium, and we can see where the myocardium collects gadolinium and where it doesn't. If we do that, we find that we're talking about 60 to 90% sensitivity and upwards of 75 to 100% specificity. If we throw in, because we can do this with MR, if we throw in a cine examination, if we look at wall motion as well as perfusion, look what we do to the sensitivity and specificity. We get up to 100% or so sensitivity and upwards of 90% specificity. So MR perfusion as an isolated test is not nearly as valuable as MR perfusion when performed with cine examination. Here's such an examination. As we move from the base of the heart towards the apex, and as we move through time from intravenous administration towards perfusion, the contrast was given intravenously. It enters the blood pool through the venous side, right atrium, right ventricle, out to the pulmonary circulation, comes back to the left ventricle, and starts to perfuse the ventricular myocardium. If we look carefully, we can see that there are black filling defects along the posterior aspect of this ventricle. Let me show you a smaller picture. We can see that there's inferior, this portion of the endocardium is not being perfused as compared to the rest of the ventricular myocardium. That's a defect. Okay? This is an inferior septal defect in the patient with right coronary artery occlusion. One of the nice things we can do with MR is we can play games with the pulse sequences so we can exaggerate the difference in signal between the perfusion defect and the rest of the myocardium by pre-saturating the tissue. And here we can see this is the same patient, and here we can see this is the defect. This is the perfusion defect, exactly analogous to a nuclear study. The advantage of MR, however, is that we can do multiplanar acquisitions, so we can look at the full extent of this ischemic zone and see that it extends not just through this one segment, but all the way back along the diaphragmatic surface of the ventricular myocardium, thus allowing us to quantitate, if you will, the myocardium at risk. Let's switch gears a little bit and talk about valvular heart disease. I lifted this slide from Waller, a cardiac pathologist. He looked at a series of 1,400 patients over 15 years in which 1,700 valves were removed for valvular heart disease. Well, you can see this is an old study. This goes back to the 80s. We don't see nearly as much valvular heart disease as we did 30 years ago. But let's look at something real important. If you look at 96% of the patients and 95% of the valves excised in surgery, what we're really seeing is aortic and mitral disease. We're seeing aortic stenosis and aortic regurg, mitral stenosis and mitral regurg, and mixed aortic and mitral stenosis. So we're really only talking about aortic and mitral valve disease when we talk about acquired valvular heart disease. I'll spend 2 minutes talking about tricuspid regurgitation because it's so relevant, but we're really talking about mitral and aortic valve disease now. And when we talk about valvular heart disease, we have to talk about rheumatic heart disease. About 25% of all patients with rheumatic heart disease have pure mitral stenosis. Mitral stenosis is the end result of chronic, long-standing rheumatic heart disease. In the acute stage, rheumatic heart disease results in mitral regurgitation. It's a pancarditis. The valve annulus gets lax, and you start developing valvular regurgitation. Left side regurgitation, mitral regurg, right side regurgitation, tricuspid regurg. Over the course of time, you develop a fibrotic response. Your endothelium thickens, your valve function gets worse, the valve area decreases, and mitral stenosis results. About 40% more patients have mixed mitral regurg and stenosis, and 67% of all women with rheumatic mitral stenosis, 67% of all patients with rheumatic mitral stenosis are women. You know, women in coronary artery disease is a hot topic, but more women have valvular heart disease and more women have congenital heart disease than do men as well. The typical radiographic appearance of a patient with mitral stenosis is that of chronic, long-standing left atrial hypertension. The left ventricle is normal. Mitral stenosis protects the left ventricle. But rather, because of the long-standing left atrial obstruction, the left atrium is dilated. Because of the chronic, long-standing left atrial hypertension is transmitted back to the pulmonary veins. They have no valves. The pulmonary veins transmit the pressure across the capillary bed to the pulmonary arteries. Everybody with mitral stenosis has pulmonary artery hypertension. Early on, it's a so-called passive post-capillary pulmonary hypertension. But over time, the arteriolar bed, the precapillary arteriolar bed, begins to respond to this insult, and you begin to develop a precapillary arteriolar vasoconstriction So you have a precapillary pulmonary hypertension superimposed on the postcapillary. If you operate soon enough, that postcapillary is resolved, the precapillary component is resolved, people do well. If you don't, if you operate later and later, if you miss the diagnosis, then the precapillary supervenes, and these people run the risk of developing permanent pulmonary hypertension despite having the valve fixed. The central pulmonary arteries and the main pulmonary artery are going to be enlarged in these patients. The peripheral vessels, you're going to have difficulty visualizing them because of the interstitial edema and the interstitial fibrosis these people have. The lower lobe vessels are always going to be indistinct. The upper lobe vessels are always going to be bigger. Okay? This is mitral stenosis. The chronic changes, therefore, are left atrial enlargement, left atrial calcification, which is generally seen best on CT. The presence of left atrial thrombus. The most common complication of mitral stenosis is atrial fibrillation. With atrial fibrillation, you have disordered atrial contraction. You develop thrombus formation, predominantly in the left atrial appendage. Over the course of time, as left atrial pressure continues to remain elevated, you start stretching the interstices of the pulmonary venules, and whole blood products, red cells and white cells, can now make it out of the blood pool into the interstitium of the lung. The phagocytic system of the lung will remove the red cells and white cells, but will leave the hemoglobin behind. The hemoglobin becomes a nidus of calcification, and you develop pulmonary calcification, hemosiderosis. Eventually, over long periods of time, that arteriolar vasoconstriction causes a proximal pulmonary artery hypertension. These people develop pulmonary vascular occlusive disease and die in progressive right heart failure. Here are two patients with chronic long-standing mitral stenosis. Big, huge left atrium, double density, wall-to-wall left atrium. The pulmonary artery is enlarged, and a lot of interstitial change. Here's an axial CT examination in such a patient. First of all, the left atrium is enormous. But I draw your attention to the size of the pulmonary artery, ascending aorta, and right atrial appendage. The right atrial appendage is dilated because of the chronic long-standing right atrial hypertension caused by the right heart failure. And the pulmonary artery segment is bigger than the aorta, a sign of pulmonary artery hypertension. Here's an axial MR examination of a patient with mitral stenosis showing the dilated left atrium, the dilated pulmonary vein, a lot of signal in the lower lungs, posterior lower lungs. Remember, protons is water. Proton signal is edema on an MR examination. People have interstitial edema. And the mitral valve itself is thickened, doming, and is a narrow orifice there. The left ventricle is normal. Principal causes of mitral regurgitation. Degenerative heart disease is the most common, so-called floppy mitral valve syndrome. Rheumatic heart disease in the acute phase. Most patients with rheumatic mitral regurgitation see it acutely, not chronically. Endocarditis, you burn out a piece of the valve. Ischemic heart disease, papillary muscle dysfunction. The myocardium doesn't contract normally. The leaflets don't coap normally. You develop regurgitant jet. And occasionally congenital malformations of the mitral valve. The typical appearance of a patient with mitral regurgitation is dilatation of the left atrium, convexity along the left heart border, dilatation of the left ventricle, increased curvature and extension of the left ventricular contour towards the chest wall, filling of the retrocardiac space superiorly and inferiorly, left atrial and left ventricular enlargement. Notice that the pulmonary artery segment itself and the pulmonary vasculature is near normal. People with mitral regurgitation don't get pulmonary hypertension because it's an intermittent process. It's only early during ventricular systole that left atrial size increases and left atrial pressure increases, and over the course of months to years, the left atrium and the left ventricle dilate, taking up this volume load, so you don't develop the pulmonary hypertension. So we tend to see the biggest left atrium and normal-looking pulmonary arteries in patients with mitral regurgitation, and smaller left atrium and worse-looking pulmonary arteries in mitral stenosis. This is an angiogram, RAO view. Catheter comes around the retrograde into the left ventricle. This is a diastolic frame and a systolic frame. From diastole to systole, the left ventricle contracts. The left ventricle likes mitral regurgitation. You're volume loading the ventricle. You're moving along the Starling curve. And from the left ventricle, we eject into the aorta as well as into the left atrium. The opacification of the left atrium is generally greater than the opacification of the aorta in severe cases. Mitral valve prolapse is associated with mitral regurgitation in about a third of cases. Murray referred to people over the age of 50 with ASDs who have dilated left atrium. About 30% of patients with ASD have mitral valve prolapse, and about a third of them, or 10% of all patients with ASD, have mitral regurgitation. So the mitral regurgitation will volume load the left atrium and change their radiographic appearance. This is a patient with mitral valve prolapse without mitral regurgitation. During diastole, the left ventricle is filled, and during systole, we can see that here's the annulus of the mitral valve. The posterior mitral leaflet is pooching back into the left atrium, but we're not seeing contrast getting back there. 2/3 of patients with mitral valve prolapse do not have regurgitation. Here's a patient with mitral regurgitation and mitral valve prolapse, an RAO sagittal section, gradient echo acquisition, and with a little imagination, you can see this redundant posterior mitral leaflet. And during ventricular systole, it's supposed to be pulled into the left ventricle for coaptation with its anterior partner. Here it's bulging back into the left atrium, prolapsing. Okay? And this patient happens to have mitral regurgitation as well. This is a patient that was sent to us with a question of a left atrial tumor. This is a mesenteric fat coming up through a hiatus hernia. But this patient has a hypertrophic cardiomyopathy. Look how thick the left ventricular myocardium is. And this is an early systolic phase. And with a little imagination, you can see the anterior mitral leaflet moving towards the thickened interventricular septum, narrowing the left ventricular outflow. Because these patients have such thick septums, there's an acceleration of flow out the left ventricle into the aorta, and that acceleration drags the anterior leaflet anteriorly, so-called systolic anterior motion, SAM. That does two things. That worsens this gradient, eliciting greater acceleration, which pulls the anterior leaflet still faster towards the interventricular septum, but it also draws the anterior leaflet away from its posterior partner, thus inducing mitral regurgitation. Look how big this left atrium is. Okay? So it's almost obligatory. There's a mechanistic association between mitral regurgitation and hypertrophic cardiomyopathy. Aortic stenosis comes in two basic flavors: congenital and acquired, so-called degenerative calcific aortic stenosis. The most common cause of congenital aortic stenosis is the bicuspid valve, most common cardiovascular anomaly we see. People with a bicuspid aortic valve are born without a gradient across their valve. Okay, there's no gradient. But the valve is malformed, so there's turbulence in the aortic root, and the response of the aortic valve leaflets to this turbulence is a fibrocalcific reaction, so the leaflets thicken and the orifice progressively narrows. So most patients with congenital bicuspid aortic stenosis have a gradient by the time they're 10 or 12 years of age. Degenerative calcific aortic stenosis is an acquired lesion. After decades of wear and tear of pumping 60 to 80 beats per minute, 5 liters per minute, and so forth, you develop a calcific degenerative change, and the leaflets get thicker, and the orifice narrows, and you thus have a gradient. Because this is an academic institution, we're going to talk about other causes of aortic stenosis, and if anybody sees a case of brucellosis or ochranosis, please copy the films and send me the originals. Congenital aortic stenosis in short axis section has a typical appearance. There are two leaflets. So we can see the anterior and the posterior leaflet. This is the orifice of the aortic valve. This is the root of the aorta. Here's the left atrium, the right ventricle. About a third of all patients with bicuspid aortic valves have pure aortic stenosis. Another third are purely regurgitant, and a third have mixed lesions. So if you do the arithmetic, about 2/3 of patients have regurgitation, and about 2/3 of patients have stenosis. It's like the producers is 133%. This is a specimen and a multi-detector CT examination. We now understand that calcification of the aortic valve does not necessarily impart the diagnosis of aortic stenosis. Calcification of the aortic valve we call aortic sclerosis. Okay? It's calcification of the leaflets that go on to cause the orificial narrowing and the gradient. And here there's a clunk of calcium in the region of the aortic valve. Okay? Look how thick this left ventricular myocardium is, and look how small the cavity of the ventricle is. Here in axial section, because of the very thin sections we can acquire with multi-detector scanners, because of the rapid acquisition, we can differentiate leaflet calcification from the degenerative process of annulus calcification. The radiographic appearance on plain film is absolutely typical. The left ventricle is hypertrophied but not dilated, so we have a very round appearing left ventricle. On the frontal view, this appearance of the left ventricle, this rounded left ventricle, is typical for hypertrophy or dilatation or ischemia or cardiomyopathy. It's a very sensitive but nonspecific finding. If we look at the lateral, however, we see that the left ventricle is not dilated. The posterior, the inferior retrocardiac space is open. So this is changing the contour on the frontal view without dilatation on the lateral view. That's hypertrophy. The ascending aorta is just barely crossing the right hilum. In lateral view, the ascending aorta is beginning to fill the retrosternal space. I know for 4.5 days this week, filling the retrosternal space is masses and malignancies, but for 2 hours on Thursday, it's dilatation of the ascending aorta, dilatation of the pulmonary artery. So these people have dilated aortas, hypertrophied left ventricles, and in lateral view, in the geographic center of the heart, we almost invariably see calcification. Calcification of the aortic valve means just that, the valve is calcified. Young people who have bicuspid aortic valves will show calcification earlier. Old people who have bicuspid aortic valves show calcification as well. So calcification doesn't differentiate between bicuspid aortic valve disease and acquired aortic valve disease. It depends when we take the picture. If we see calcification in a young person, we know it's a congenital lesion. If we see it in an old person, we can't differentiate. They're exactly the same. Here's an angiogram of a patient with aortic stenosis, retrograde cannulation of the ascending aorta. During ventricular systole, unopacified blood from the left ventricle fills underneath the aortic valve leaflets. The aortic valve leaflets can't open to their full width, the full orificial area during ventricular systole, so they billow up, and we see this so-called doming effect. At the center, or near the center of the dome, is a signal void jet. This is the jet of unopacified left ventricular blood getting into the mildly dilated ascending aorta. We now understand that poststenotic dilatation is caused by a breakdown in the cross-links of the collagen and elastin in the ascending aorta. Trick question, what's the pressure in the ascending aorta, the patient with aortic stenosis? The answer is normal. Okay, these people aren't hypertensive. They have normal pressure in the aorta. It's just the cross-links of the aortic wall breaking down. Here's an axial gradient echo acquisition in a patient with aortic stenosis, where during ventricular systole, we see the myocardium is thickened, the cavity of the ventricle is smaller, we see a signal void jet. In fact, the entire ascending aorta is deopacified with the turbulent flow. The turbulent spins are moving in every which direction, they null each other out, so there's a net zero signal. We can correlate the severity of the obstruction across the valve by how far into the ascending aorta we see the signal void jet. Here are a couple of patients with aortic stenosis, just showing you the different shapes of jets. Okay? The shape of the jet on the MR examination is really related to the shape of the orifice of the aortic valve and the imaging plane we use. You can imagine that if we have an eccentric orifice and we image in one direction, we'll see a broad jet. If we image at right angles to that, we're going to see a narrow jet. So it's not a typical appearance, but all of the jets share in common their origin at the level of the aortic valve into the ascending aorta, and they're all during systole. Here's a patient with aortic stenosis, and I draw your attention to the thickened leaflets of the aortic valve, which is so typical. And during systole, 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 you have to learn to beat time to do MR. Systole, systole. We see the signal void jet extending towards the ascending aorta and actually caroming off into the rest of the ascending aorta. The left ventricular myocardium is hypertrophied, the result of the outflow obstruction. Aortic insufficiency can be classified as diseases of the aortic valve and diseases of the aorta causing aortic insufficiency. Aortic valve disease causing aortic insufficiency, well, rheumatic heart disease, the most common rheumatic lesion of the aortic valve is aortic insufficiency. Endocarditis, okay, we basically gum up the leaflets of the aortic valve and there's a leak, and congenital. Remember, bicuspid aortic valves. A third of all bicuspid aortic valves are purely regurgitant. Another third have mixed stenosis and regurgitation. So we see a lot of aortic regurgitation in bicuspid valve disease. About 15% of all patients, 1 in 6 patients with a VSD has aortic insufficiency. We'll talk a little about that in a minute. And Marfan syndrome. Diseases of the aorta that cause aortic insufficiency, diseases of the aorta that cause enlargement of the aorta, stretching of the aortic annulus, and failure of the leaflets to coapse. So aortic aneurysms, you run a whole big differential there, okay? And aortic dissection. If the aortic dissection goes retrograde, it will undermine the aortic valve, will dissect between the valve leaflet and the aortic annulus and either go out into the pericardial space or back into the left ventricle, thus lifting the aortic valve off its annulus and causing aortic insufficiency. The typical appearance of a patient with aortic insufficiency is that of pure left ventricular enlargement. The left ventricular contour is rounded. Here it's extending over to the chest wall. I think we can all agree this left ventricle is dilated, but the lateral view shows that there's no inferior retrocardiac space. This is a dilated left ventricle. The ascending aorta doesn't always cross the right hilum, but starts to fill the retrosternal space in the lateral view in these patients. Dilatation of the left ventricle, dilatation of the aorta. This blood is sloshing back and forth between the left ventricle and the aorta. Over the course of years, the left ventricle and the aorta will dilate. If you draw your attention to the center, the geographic center of the heart, we don't see calcification. We see many fewer patients with aortic insufficiency who are calcified than aortic stenosis who are calcified. No matter how you image the heart, we see the same business. This is a coronal and sagittal section of a patient with aortic insufficiency. The left ventricular cavity is dilated. The ascending aorta, there's the PA. The ascending aorta is greater in caliber than the PA. Okay? But I draw your attention to the left ventricular myocardium. The response of the left ventricular myocardium to the volume load is to dilate, to stretch. But there's also a homeostatic mechanism to maintain normal wall stress so that the left ventricular mass increases, so that the mass of the myocardium is increasing as the volume is increasing. Our eye just isn't as sensitive to changes in the thickness of the wall as it is to changes in the area of the cavity of the ventricle. But patients who have aortic insufficiency have increased left ventricular myocardial mass as well as increased myocardial volume. When the left ventricle dilates, it doesn't matter how you cut the ventricle. Any way you cut it, you see thickening of the wall. The jet of aortic insufficiency on an MR examination is typical. It's a diastolic jet extending from the aortic annulus along the anterior mitral leaflet into the dilated left ventricular cavity. This is a patient with garden variety floppy aortic valve disease who has aortic insufficiency and left ventricular dilatation. This is a patient with Marfan's disease who doesn't have an aortic dissection, but we see the tulip bowl aortic root, the effacement of the sinotubular junction, and the signal void jet extending into the dilated left ventricle. Here's a gradient echo acquisition. And again, follow the signal void jet, and they almost invariably bounce off the anterior mitral leaflet into the dilated left ventricle. Notice that the contraction is vigorous. The left ventricle likes to be volume loaded. It's moving along the Starling curve. Now, this is a patient with a VSD. AP and lateral aortogram, catheter comes retrograde around the arch and into the aorta, left coronary artery. Upon injecting the aorta, we see some filling in here. Okay, aortic insufficiency, okay, into the left ventricle. In lateral view, we get a better view. Here's a notch. Okay, here's the root of the aorta. There's that contrast getting into the left ventricle. But we see this notch in here. What happens in these patients is that their VSD is directly beneath their aortic valve. So the aortic valve isn't being supported properly. What happens is that sinus of Valsalva will fall into the VSD. And when that sinus falls into the VSD, it draws its leaflet away from its partners, and you induce aortic insufficiency. You can imagine that if this goes on long enough, this sinus of Valsalva can not only fall into the VSD, but actually close it off spontaneously. And in about 5% of patients, or a third of people who have VSD and AI, we see a spontaneous closure of the VSD by the aortic valve falling into the aortic sinus, falling into that VSD. What happens is they lose their shunt gets turned off basically, but they develop significant left ventricular volume loading. So their clinical and radiologic appearance changes dramatically. That's called the Lowry-Petsy syndrome. And finally, tricuspid insufficiency. Everyone talks about Ebstein's malformation. Has anybody seen a fresh case of Ebstein's malformation in the last 5 years? Most tricuspid insufficiency is caused by pulmonary hypertension. When the right ventricle becomes hypertrophied, the shape of the septum changes. Now, the left ventricle gives papillary muscles from the free wall and the interventricular septum. The right ventricle gives papillary muscles from the interventricular. I'm sorry, the left ventricle gives papillary muscles from the free wall. The right ventricle gives papillary muscles from the free wall and the interventricular septum. So when the interventricular septum changes shape, you induce tricuspid insufficiency because the papillary muscles coming off the septum don't pull on the tensor apparatus in the right direction. So tricuspid insufficiency is almost invariably seen in patients with right ventricular hypertrophy. And the common causes of right ventricular hypertrophy are pulmonary artery hypertension and right ventricular hypertension. The appearance of tricuspid insufficiency is that of a very dilated right heart. It's commonly associated with mitral valve disease, so we see a dilated left and right heart. The most common presentation of tricuspid insufficiency is with a big heart. MR examination of 2 patients with tricuspid insufficiency. Axial views, we see a signal void extending from the tricuspid valve into the right atrium during systole. This is a patient with more severe disease. Look how the right ventricle is so much thicker. The interventricular septum is in this orientation. That septum should be looking this way. This heart is rotated into the left chest, and we see the signal void jet extending from the tricuspid annulus into the right atrium. Okay, let's finish up with some pericardial disease. Pericardial effusion on lateral view. The pericardium is formed by the 2 leaves of the pericardium, which are separated by the epicardial fat and the pericardial fat. So with a little imagination, you might see the pencil-thin line of the 2 leaves of pericardium. If you put fluid into the pericardial space, then the 2 leaves are separated by this signal, by this fluid signal. So in lateral view, we see separation of the epicardial fat and the pericardial fat by the fluid-filled pericardial space, so-called Oreo cookie sign. On a CT examination, pericardial fluid is demarcated by soft tissue density or low signal intensity material between the epicardial fat and the pericardial fat. This is the pericardial space. On an MR examination, spin echo acquisition shows a signal void separating the epicardial fat from the pericardial fat, and gradient echo acquisition shows a high signal within the pericardial space. This is a patient with a right atrial mass extending up from the kidney. It's a hypernephroma through the IVC. The appearance of hemorrhage, generally looks denser than does conventional fluid, but also is more dramatic. In other words, when something bleeds, it's bleeding at systemic pressure more often than not. So we see enormous extrinsic compression. This is a patient who has spontaneous pericardial hemorrhage. This is the right coronary artery being displaced medially by this big pericardial hemorrhage. If you put cursors on this, you find that it's high signal intensity, it's blood. Pericardial calcification is the result of previous inflammatory insult to the pericardium. It doesn't necessarily mean that there's a physiologic insult to the heart. So pericarditis, calcific pericarditis, means that the patient had pericarditis at some point. If the pericardial calcification is thick enough and it prevents diastolic filling of the ventricles, then we get into the situation known as pericardial constriction. And pericardial constriction has to be differentiated from myocardial restriction because the outcome of the 2 diseases, as Marie described, is very different. The appearance of calcification of the heart on a plain chest film is characteristically thick and ugly-looking calcification along the inferior and right border of the heart. The left ventricular myocardium calcifies on the left of the heart. There is no myocardium on the right heart to speak of. So calcification on the right heart or on both sides implies pericardial calcification. The calcification is anterior and inferior and clunky and ugly. Again, second-generation CT scanner. Peripheral calcification around the heart involving the left side of the heart and the right side of the heart is typical for pericardial calcification. Myocardial calcification is exclusively along the left side of the heart. These are multi-detector CT reformat exams as a patient with pericarditis. We have fluid between the visceral and the parietal pericardium. There's calcification along the visceral and the parietal bands of the pericardium. It's typical of calcific pericarditis. If the pericardium itself thickens, that's pericarditis without calcification. This is a patient with history of tuberculosis. With a little imagination, we might see the pencil-thin line of the pericardial space. But look at the distance between the cavity of the right atrium and the lateral border of the heart. That should be barely 2 millimeters. This is thickening of the pericardium. We see the pericardium is thickened as it reflects over the top of the pulmonary artery and up the ascending aorta just inferior to the azygous vein. If we cut this patient in axial section, there's that pencil-thin pericardial space, the thickened pericardium, surrounding the heart. Pericardial constriction results in failure of the ventricles to dilate adequately. What happens is that they can't distend during diastole, atrial pressure rises, and if they can't maintain atrial pressure to maintain filling of the ventricles don't get filled. If the ventricles don't get filled, you don't maintain your cardiac output. They don't empty. So look at the lack of excursion of the right ventricle, how poorly this ventricle is filling and emptying. There's a little bit of tricuspid regurg. But look at the space around the heart. A pericardial effusion would look like a pleural effusion. It'd be white. This is thickened pericardium. This is a thickened pericardium causing constriction. And finally, let me talk just a little bit about pericardial cysts. Pericardial cysts present as densities on chest films. They're of iso-intense or slightly higher signal intensity on T1 weighted images, and they light up on T2. They're filled with fluid. Here's another patient. This is a really subtle one. The finding here is that the right hilum is elevated as compared to the left hilum. In coronal section, we can see this high signal intensity mass extrinsically compressing the left atrium from above and displacing the right pulmonary artery superiorly. That's what the chest film came from. If we fat saturate the image, we find that this thing doesn't disappear. Look at the fat in the breast. So this thing is not fat. And if we do a multi-echo acquisition from the 20 to the 80 millisecond echo, we see that the signal intensity of all tissues gets less except this. This thing isn't lighting up on T2, but rather this thing is losing signal less rapidly. This is a fluid-filled structure within the heart. This is an intracardiac pericardial cyst. A pericardial diverticulum is a failed pericardial cyst. The way pericardial cysts form is a piece of the parietal pericardium pinches off from the visceral and forms its own little pericardial sac, and that's a cyst. If this pinching isn't complete, then we get a diverticulum. A diverticulum looks and smells exactly like a pericardial cyst, only if you're lucky, you can trace its continuity with the pericardial space, or the surgeon will just tell you at operation they found that continuity. And finally, just a little bit about malignancies. The common malignancies of the heart are metastatic, breast in women, lung in men. The next most common malignancies of the heart are primary benign. Tumors of the heart are primary benign, like a lipoma. Here's a patient with a high signal intensity area which involves the papillary muscle. If we fat saturate this patient, we find that this signal intensity disappears, as does the fat here. So it's a fatty tumor. Okay, a couple of sections. It's a big one. It extends into the papillary muscles. Benign lesion. Here's a patient who had 2 lesions. This is a melanoma. While being worked up for her melanoma, we discovered this mass, decreased signal intensity mass within the left atrium. And this mass in the left atrium is attaching to the interatrial septum. This is a myxoma in a patient with a melanoma. The melanoma was treated interferon, and this was treated surgically. Most of these diagnoses can be made by paying attention to expected normal, what you expect to see, and looking for abnormal contours. If you put this stuff together, if you think about the mechanisms that make the left atrium big and make the left ventricle big and so forth, you can begin to construct differential diagnosis. Thank you. So let me take you through this and point out what catches my eye, and we'll talk about some issues here. Okay, so this is a young kid, 20-year-old kid with a chronic history of shortness of breath. And if we look at the film, first of all, the guy's got an intravenous line. And again, we go from science to philosophy now, talking about the boards. Everything's important. Nothing's not important. If you make sure you look at lines, make sure you look at the chest wall, make sure you look at ribs and look at bones and everything, okay? This guy's got an intravenous line that's in the superior vena cava. What catches my eye about this guy is that the pulmonary arteries, the main pulmonary artery and the hilar left and right pulmonary arteries catch my eye. They're large. Okay. Normally we go about 1 bronchus in dimension, but these are prominent central pulmonary arteries. And I would also argue that the vessels in the lower lung zones are unsharp and bigger in caliber than the vessels in the upper lung zones. That's a very important consideration, because normally the lower lobe vessels are going to be bigger than the upper lobe vessels. We're upright creatures, and there's more lower lobes for perfusion, so more blood gets down there, more blood comes back up. But the pulmonary arteries are enlarged. That catches my eye. In lateral view, you get the impression that the superior retrocardiac space is probably a little filled, and the left ventricle is dilated as well. We're filling the inferior retrocardiac space. So we've got left atrial and left ventricular enlargement, and we've got evidence of big central pulmonary arteries and what looks like left atrial hypertension. Okay? So we can begin to run a differential diagnosis of heart failure in this patient. The big pulmonary arteries, however, make us consider an alternative form of heart failure as high output cardiac failure. Okay? There are people who have low peripheral resistance, and heart failure. And the heart failure in face of low peripheral resistance, the cardiac output is higher, actually. That's what we call high output cardiac failure. So we have to consider causes of high output cardiac failure. And I would argue that the most common causes of high output cardiac failure are shunts, okay, AV malformations, things along those lines. And in childhood, they look like shunts. In older people, they start to look a little bit more like failure. And you have to worry about bone disease, Paget's disease, sickle cell disease, okay? In other words, the bones become a very big peripheral sink. The bones have a great volume, and the volume of the bones increases. I think Murray showed a case of thalassemia with big pulmonary arteries and big, thick bones. And if you look carefully at the ribs, at the spine in this kid, I think I've got a blow-up over here, he's got H-shaped vertebrae. This is a kid with sickle cell disease and high output failure, okay? There's a proliferation of the marrow space. This becomes a big peripheral resistance sink. Peripheral resistance goes down. These kids are in high output failure, okay? Furthermore, because they're anemic, their failure is worse, okay? They're trying to move around oxygen to their peripheral tissues. The red cells aren't functioning normally, so they put out more cardiac output to make up for it, okay? Here's a patient who's minimally symptomatic with a murmur, okay? The aortic arch segment, the pulmonary artery segment. The pulmonary artery segment catches my eye. The right pulmonary artery segment, hilar pulmonary artery, catches my eye. Now, one thing I don't see on this examination is I don't see the left pulmonary artery, okay? And the reason you don't see the left pulmonary artery most commonly is because the right heart dilates and rotates. When the right heart dilates, it rotates looking from below in a clockwise manner. So in this patient, the superior mediastinum is relatively narrow, and the left bronchus doesn't cross the left heart border, but rather it's parallel to the heart border. In other words, the left bronchus, the two bronchi sit over the top of the atrium, behind the heart. When the right heart dilates, the heart rotates into the left chest, okay? The bronchi stay put. So the projection of the left bronchus crossing the left heart border no longer happens. So we have is filling of the retrosternal space, rotation of the heart, the left bronchus is parallel to the heart border. That's right heart dilatation. So the left pulmonary artery is now behind the heart, and we don't see it. If you don't see the left pulmonary artery, it's generally a good sign the right heart's dilated. And in face of a dilated main pulmonary artery and a hilar right PA, we have to begin to construct differential diagnosis. Now, the differential diagnosis of a big pulmonary artery segment is increased pressure, pulmonary hypertension, that's a whole differential diagnosis. Increased flow, left to right shunts, and that's a whole differential diagnosis. Increased pressure and flow. You know, everybody with an ASD has increased pulmonary blood flow, but everyone with an ASD doesn't have pulmonary hypertension. Pulmonary hypertension in ASD under the age of 20 is almost reportable, less than 5%. But between 20 years of age and 40, 50 years of age, there's a progressively increasing incidence of pulmonary hypertension in patients with ASDs. So all ASDs don't have pulmonary hypertension, but some patients with pulmonary hypertension have ASD. So we have to consider that. The exception to the rule is valvular pulmonic stenosis. Now, in valvular pulmonic stenosis, the main PA is enlarged. The proximal left PA is enlarged. And in fact, sometimes the very proximal right PA is enlarged. But by the time that right PA makes it to the hilum, it's come back to normal size. We don't see it. So pulmonic stenosis is the exception to this rule. Why is it an exception? Well, trick question. What's the pressure in the pulmonary artery in a patient with pulmonic stenosis? The answer is normal. What's pulmonary blood flow in a patient with pulmonic stenosis? It's normal. By definition, if the right ventricle can't maintain pulmonary blood flow because the obstruction is so severe that no matter what pressure the right ventricle generates, it can't maintain flow, that's critical pulmonic stenosis, and these people don't show up like this. These people show up in terrible, terrible heart failure if they're not maintaining their cardiac output. So pulmonic stenosis is the exception, but it's an important consideration because pulmonic stenosis is a very common congenital malformation seen in adults. We tolerate right ventricular hypertension and pulmonic stenosis very well. Nevertheless, this patient has a big pulmonary artery, big hilar vessels. The lower lobe vessels are big, the upper lobe vessels are big. When the lower lobe vessels and the upper lobe vessels are both big, that's a sign of a shunt. The only things that cause increased caliber of the upper lobe vessels is going to be redistribution, left atrial hypertension, and shunt. In redistribution, the lower lobe vessels start to disappear because of the interstitial change, which causes the redistribution. And in shunt, the lower lobe vessels are big and the upper lobe vessels are big. So this is a patient who's got right-sided enlargement and shunt vascularity. If we look in the lateral view, the tracheal air column comes straight down. There's no posterior displacement of the tracheal air column. There's no evidence of left atrial enlargement. A shunt with a normal left atrium is an ASD till proved otherwise. Okay? This is a patient with an ASD. Now here's a young woman with progressive shortness of breath. She too has a big pulmonary artery segment. Okay? And her hilar right pulmonary artery catches my eye. But her lower lobe vessels are big and her upper lobe vessels are not big. Okay, in fact, we barely see them. So this is a patient who's got a big pulmonary artery segment, big central pulmonary artery. We don't see the left. There's the left through the heart. There's some right heart dilatation here. And as we said before, remember that the most common cause of tricuspid insufficiency is pulmonary hypertension. So almost everybody with pulmonary hypertension has some tricuspid insufficiency. So we almost invariably see right heart dilatation in these patients. But this patient has a big central pulmonary artery, and the lower lobe vessels are bigger than the upper lobe vessels. So the differential diagnosis here would not include shunt. We would put shunt down below in the differential because there's no evidence of shunt vascularity. So since we throw out shunt, we're going to consider increased pulmonary artery pressure first. This is a patient with pulmonary artery hypertension. Okay? Differential diagnosis of pulmonary hypertension, you should have a good long... Pulmonary hypertension is one of the few things in cardiac medicine we should have a big, long differential diagnosis. The most common cause of pulmonary hypertension in the world is schistosomiasis. Schistosomiasis typically shows up as pulmonary hypertension, but we see diffuse bilateral interstitial infiltrates. That's the immune response of the lung to the schistosome. Okay? In the West, the most common cause of pulmonary hypertension is obstructive lung disease. These people show up with pulmonary hypertension, but they have hyper-aerated lungs. The hearts tend to be small. The diaphragms tend to be flat. The AP dimension of the chest is generally increased. The next most common cause is going to be restrictive lung disease, interstitial lung disease. The model in children is cystic fibrosis, bronchiectasis, diffuse lower lobe interstitial change. The model in adults is interstitial pulmonary fibrosis, interstitial change predominantly in the lower lobe. So we would expect to see in a patient with interstitial lung disease causing PH, we expect to see interstitial change. Okay? Then we get to chronic thromboembolic disease. A single solitary pulmonary embolus will not cause pulmonary hypertension, but rather you've got to knock off about 50% of your pulmonary bed before you develop pulmonary hypertension. If you consider the pulmonary tree, not as a tree, well, let's consider the pulmonary artery system as a tree. If you consider this tree, if you're looking down upon it, if you chop off, you cut straight across the tree, so you're looking down, and rather than seeing branching limbs, you're seeing a collection of cross-sections of the limbs of the tree. The sum of the area of the cross-sections of the limbs is the pulmonary arterial bed. That's the area of the bed, if you will. You have to knock off about 50% of that bed, the area of that bed, before pulmonary resistance rises. Take, for example, people who have traumatic pneumonectomies. People get into automobile accidents or have gunshot trauma, whatever, where the surgeon removes a lung. These people now have the situation where the opposite lung, the lung that was left behind, has increased flow by 2. You've doubled the flow in this lung. The flow in this lung is not causing pulmonary hypertension because that bed is still normal and it distends to make up for it. So you have to knock off a significant piece of your pulmonary arterial bed before you develop high resistance pulmonary hypertension. So a single solitary pulmonary embolus doesn't do this. But most people who have pulmonary embolus, they must have their first sometime, but most people who have pulmonary embolus have chronic pulmonary embolus. They're always showering pulmonary emboli. So at some point, they pop off enough of their pulmonary arterial bed, the resistance rises, the right ventricular pressure rises to maintain forward flow, and the pulmonary artery pressure rises, and they present as pulmonary hypertension. So chronic thromboembolic disease is a good cause of pulmonary hypertension. The interesting thing about chronic thromboembolic disease is that most of these patients present with one of two ways. Either they present with a pleural effusion, so the lung scan is indeterminate, and that's why we do CTs without getting lung scans anymore, or they present with what looks like almost normal-looking lungs, pulmonary hypertension, big central PAs, small peripheral PAs, but normalish looking lungs. So they're a difficult case to make a diagnosis on a plain film, and they're difficult to exclude from the differential diagnosis, but we have to include in the differential diagnosis. Well, we've now included obstructive lung disease, restrictive lung disease, and chronic thromboembolic disease. That's about 80% of all patients with pulmonary hypertension. Then we get to cardiac disease causing pulmonary hypertension. There was a time when the most common cause of cardiac disease causing pulmonary hypertension was mitral stenosis. Mitral stenosis is chronic long-standing left atrial hypertension. The pressure is transmitted across the bed. Since we're in an antibiotic era and we've virtually eradicated mitral stenosis, certainly in the West, we still see it in immigrant populations, ischemic heart disease is the most common cause of left atrial hypertension. Okay? When the left ventricular myocardium ages and when it gets ischemic, its compliance decreases. That means its distensibility, its stretchiness is lost. So what happens is left atrial pressure has to rise to maintain filling of the left ventricle during diastole. So you start off with left atrial hypertension. That left atrial hypertension is transmitted across the bed. Pulmonary veins have no valves. So you're transmitting left atrial pressure to the right side of the circulation, so-called passive pulmonary artery hypertension. Okay? So we see this in patients with ischemic heart disease. Now, we don't see as much as we used to because we treat ischemic heart disease so dramatically, so aggressively. But ischemic heart disease is the most common cardiac cause of pulmonary hypertension. Then we have shunts. Okay? You can classify shunts as pre-tricuspid valve shunts or post-tricuspid valve shunts. Well, that's a very fancy way of saying ASD and VSD and duct. Think about the blood flow. With an ASD, the flow is during diastole. In an ASD, the two atria communicate with each other because there's an ASD, and the two atria communicate with their respective ventricles because it's diastole and the AV valves are open. So the direction of blood flow in an ASD is going to be determined by the compliance of the ventricles. And the compliance of the ventricles is going to be determined by the resistance that those ventricles are seeing. In other words, in the newborn period, the right ventricle comes into the world hypertrophied. In utero, the right ventricle is hypertrophied. You look at a study, look at an MR or an echo or a CT of a newborn, the right ventricle is just as thick as the left ventricle. But pulmonary resistance is falling in the newborn period, and systemic resistance has risen when the placenta came out of circulation and maintains high. So the right ventricle is becoming more compliant as it loses myocardial mass. By 3 months, the right ventricle has reached its normal 2 or 3 millimeter thickness. So the right ventricle is much more compliant than the left ventricle. So during diastole, the blood flows from left atrium to right atrium. Systemic venous blood coming back to the right atrium meets this pulmonary venous blood. The right atrium is dilated, the right ventricle is dilated, the pulmonary arteries are dilated, the pulmonary veins are dilated. Back to the left atrium. Trick question: what's the volume of the left atrium and what's the flow through the left atrium? Well, the volume of the left atrium in an ASD is normal. The volume of flow through an ASD is increased, through a left atrium is increased because it's going in two directions. It's decompressing across the atrial septum and across the mitral valve. Left atrium onto the left ventricle. So the right heart is dilated, the left heart is not dilated. The pulmonary artery pressure in these patients is normal. Pulmonary resistance is normal. Nothing that we've described so far changes pulmonary arteriolar tone. So patients under the age of 20 with an ASD don't have pulmonary hypertension. As the left ventricle ages and compliance of the left ventricular myocardium begins to drop, okay, it becomes a race. As left ventricular compliance lowers, left atrial pressure begins to rise. And as left atrial pressure begins to rise, we start to drive the shunt left to right. In a 20-year-old, there's no gradient across the atrial septum. Left atrial pressure and right atrial pressure are equal. But in a 30 or 40-year-old, there's now a gradient. We're taking this maximally vasodilated pulmonary bed, and now we're insulting it further by increasing the shunt. When you increase the shunt in the 20s, 30s, and 40s, then you start getting a vasoconstrictive reaction by the arteriolar bed. Pulmonary resistance rises. Pulmonary artery pressure begins to rise. So we start seeing pulmonary artery hypertension in ASDs. So our judgment of pulmonary hypertension in ASD is more a function of the patient's age, okay, than anything else. In a VSD, VSDs come in two big varieties, big VSDs and small VSDs. Big VSDs, there's no gradient across the interventricular septum, so during ventricular systole, the left ventricle ejects into the right ventricle. The right ventricle sees systemic pressure. The left ventricle is pumping against systemic resistance. The left ventricle pumps in systemic pressure. So you start seeing right ventricular hypertension, pulmonary artery hypertension. In a duct, The aorta perfuses the pulmonary circulation, so the pulmonary arteries are seeing systemic pressure. They have pulmonary hypertension. So pulmonary hypertension is much more commonly seen in VSD and ductus than in an ASD. Okay? We've now described about 98% of patients with pulmonary hypertension, and all that's left is pulmonary vein stenosis and primary pulmonary hypertension. Okay? Primary pulmonary hypertension should always be a diagnosis of exclusion. And we now understand that a form of pulmonary hypertension, primary pulmonary hypertension, involves pulmonary vein stenosis. This is a patient with pulmonary vein stenosis and pulmonary hypertension. It's a diagnosis of exclusion. Here's a 41-year-old with exercise intolerance. His pulmonary artery is big, but his hilar PAs are big, his lower lobe vessels are big, his upper lobe vessels are big. Okay? This is a shunt. His retrosternal space is filling. The superior mediastinum is narrow. The left bronchus is parallel to the heart border. The retrosternal space is filled. This is right heart dilatation. His superior and inferior retrocardiac space is filled. There's left heart dilatation. This is a VSD. So we can characterize an ASD as a shunt with right heart dilatation and a normal left heart. A VSD is shunt vascularity with biventricular enlargement. And a ductus as a shunt with left heart enlargement and normal right heart. So looking at chambers, we can judge this. This is a VSD. Here's the same patient a couple of months later. Not a whole lot different. A couple of months later, okay, not a whole lot different. If we put them together, however, we learn something about the natural history of VSD. Look at the pulmonary vascularity and look at the size of the heart. His pulmonary vascularity is becoming more peripherally vasoconstricted. And as his pulmonary resistance rises, his left to right shunt decreases and his right heart dilatation decreases. He's going on to a point where right ventricular resistance, the pulmonary resistance and systemic resistance are now catching up with each other. Normally, pulmonary resistance is only 10% of systemic resistance. He's going to begin to shunt right to left when pulmonary resistance becomes greater than systemic resistance. Then right ventricular pressure will overcome left ventricular pressure and you'll start to shunt right to left. That's Eisenmenger physiology. Eisenmenger physiology is a left to right shunt that reverses to become a right to left shunt. You can't make that judgment on a single solitary radiograph. You have to see the change, and we estimate that change by changing the volumes of the left and right hearts. Eisenmenger physiology is seen in only about 10% of patients with ASD, and it's seen in about 20% of patients with VSD. Here's another patient with chronic shortness of breath, a big pulmonary artery segment. The central pulmonary artery is enlarged. In lateral view, the left atrium is enlarged. That left bronchus displaced posteriorly. You know, there's the orifice of the left upper lobe of the right upper lobe bronchus. There's the orifice of the left upper lobe bronchus. If you draw a line through those two bronchial orifices, it goes outside the tracheal air column. That's because when the left atrium enlarges, it pushes the left bronchus posteriorly. Normally, if you draw a line between the two orifices of the bronchi, it goes straight through the tracheal air column. This is an exquisitely sensitive sign of left atrial enlargement. So here's a patient with left atrial enlargement, a normal-looking left ventricle, okay, and what looks like big central pulmonary arteries. His lower lobe vessels are indistinct. His upper lobe vessels are bigger than the lower lobe vessels. This is pulmonary hypertension with left atrial hypertension, left atrial enlargement in the normal left ventricle. This is a patient with mitral stenosis. Here's a child with a murmur. 2 years of age, 3 years later. Well, at 2 years of age, it's a slightly oblique view, and we can see that his left PA is dilated. 2 years later, we can see that his main PA is enlarged. Overall heart size is normal, okay? And he's got a murmur. It's very difficult to argue for valvular heart disease in the absence of a murmur, okay? In the presence of a murmur, you can have valvular heart disease, you can have intrinsic congenital heart disease, shunts, and so forth. But it's very difficult to have valvular heart disease without a murmur. This is a child who's got a murmur and a dilated left pulmonary artery and a dilated main pulmonary artery. The pulmonary circulation is otherwise normal. The lower lobe vessels are bigger than the upper lobe vessels. Okay, the vessels taper as they get out to the periphery. They're not increased in size. They're not decreased in size. This is a patient with valvular pulmonic stenosis. Now, kids tolerate valvular pulmonic stenosis very well because the right ventricle has known hypertrophy. The right ventricle comes into the world hypertrophic. Okay? So the right ventricle can tolerate very high pressures. We can tolerate a 70 millimeter gradient across our pulmonary valve before we get sick. Okay? So valvular pulmonic stenosis is a relatively common lesion to make it out of childhood into adulthood. And people with valvular pulmonic stenosis do very well clinically until the right ventricle becomes ischemic. That is, when they start developing superimposed ischemic heart disease on the congenital heart disease. That's when they start getting into trouble. So it's very common to see 30 and 40-year-olds with valvular pulmonic stenosis who are doing okay. Here's an asymptomatic individual. Why they get the chest x-ray, that's another story altogether, whose pulmonary artery segment looks big as compared to the aorta. The heart has drifted into the left chest. Okay, this heart is displaced way into the left chest. The pulmonary circulation doesn't do anything for me. Okay? So what are some things that can make the heart move into the left chest? Well, things that can do that are volume loss, if there's a lower lobe collapse or a pneumothorax or a right-sided tension pneumothorax, that can push or pull the heart into the left chest. A big right effusion can push the heart into the left chest. The right heart can dilate. That can rotate the heart into the left chest. Okay? And finally, what this patient has is this heart is not only pushed into the left chest, fallen into the left chest, but is significantly rotated. Look at the plane of the septum. That interventricular septum should be in this orientation. This is congenital partial absence of the pericardium. Okay? This is the kind of exam they love to kind of study, they love to show on the boards. One thing is they have a lot of cases of this. But I draw your attention to the aorticopulmonary window. Normally, there's a piece of pericardium. The pericardium reflects on the top of the pulmonary artery up to the aortic arch. And there's no lung in there. But in partial absence of the pericardium, this piece of pericardium is missing, so lung invaginates in and separates the aortic arch from the top of the pulmonary artery. Furthermore, these people, depending on how much of the pericardium is missing, and most of them have a lot of pericardium missing, have profound displacement of the heart into the left chest. And I would draw your attention to the right heart border. You don't see a right heart border. Okay? I can't document that with literature, but in our experience, this is a very common finding, or lack of a finding, if you will. Here's an asymptomatic individual, another asymptomatic individual who had a chest x-ray taken. There's a mass to the right of the trachea displacing it to the left. This is a right side aortic arch. Right aortic arches, as Murray described, come in two flavors, the anterior right aortic arch and the posterior right aortic arch. The anterior right aortic arch doesn't displace the trachea in the lateral view. They're the ones that are frequently associated with congenital heart disease. The posterior right aortic arch displaces the trachea anteriorly. These are the ones that are associated with an aberrant left subclavian artery and no congenital heart disease. And here we can see in lateral view the anterior bowing of the trachea by the mass of the aortic arch. Okay? This patient is asymptomatic, which means that there's probably no ring. Now, rings generally present in childhood. If there's a ductus remnant that connects the aberrant left subclavian artery with the left pulmonary artery, and that ductus remnant begins to shrink, it's going to pull this aberrant artery anteriorly and cause extrinsic compression of the trachea and or the esophagus, and these people present in childhood with stridor or dysphagia. Okay? If they don't present in childhood, then they're generally scot-free until they get much older. When these patients get into their 60s and 70s, and since they're not associated with congenital heart disease, there's no good reason why they shouldn't get into their 60s and 70s, and they start developing atherosclerosis, they can develop an aneurysm of this aberrant artery or something like that, and then develop narrowing of the trachea or the esophagus and present late. And if they decide to take a big chunk of steak without chewing on it, that's when they present, but not in childhood. Well, if you're given a diagnosis, you should come up with a differential diagnosis. You know, the reason this is a patient who's got a normal-sized heart, but look at the pulmonary artery segment. It's flat. We've seen big pulmonary artery segments all afternoon. This is a flat pulmonary artery segment. The pulmonary circulation is near normal. Now, I know the answer. I got the answer in front of me, so I can say, boy, look how small that right pulmonary artery segment is. The problem with tetralogy of Fallot is that it's a spectrum of illness. Okay? At one end of the spectrum, as Murray described, is a so-called pink tet. They're called pink because their right ventricular outflow obstruction is so mild, they're shunting left to right. Okay? They're pink. They're not desaturated. They're not shunting right to left. Okay? So they're a tough diagnosis to make. At the other end of the spectrum, you've got tetralogy of Fallot with pulmonary atresia, where there's an atretic pulmonary valve and no antegrade filling of the pulmonary circulation from the right ventricle. You can imagine that there's a spectrum of illness. At the pink TET side, these kids generally don't get diagnosed in childhood, don't show up until later in life when their resistance changes. At the other end of the spectrum, TET with pulmonary atresia presents earliest, they're the sickest, and they've got the most terrible outcome. Everybody else is in the middle. What characterizes tetralogy of Fallot is the malalignment VSD. These kids all have big VSDs. What differentiates kids with tetralogy is the severity of the right ventricular outflow obstruction. Nevertheless, since they all have decreased pulmonary blood flow, infundibular obstruction, they all have flat pulmonary arteries. The reason we call it tetralogy of Fallot is because Louis Etienne Fallot was the first person to make this diagnosis in life. This disease was described 200 years earlier in 1740-something, in 1640-something by Louis Sandefort, a Belgian physician. But Etienne Fallot was a very smart guy. He knew that all forms of cyanotic congenital heart disease died before they were old enough to get to his office. He practiced in 1880-something in Marseille, in France. So the only lesions that made it to his office had this diagnosis. So he made the diagnosis in life, prescribed 50 cases, and that's why we call it tetralogy of Fallot and not tetralogy of Sandefort. The differential diagnosis of a flat pulmonary artery segment comes into three basic categories. The first category is decreased right ventricular emptying, okay? Tetralogy of Fallot, TET with pulmonary atresia with VSD, double outlet right ventricle, okay? This is right sided obstruction at the level of the right ventricular outflow. The next group of patients that you see a flat pulmonary artery segment are those patients with tricuspid valve abnormalities, tricuspid atresia, and Ebstein's malformation. There, because of tricuspid atresia, there's no antegrade filling of the right ventricle, so there's no antegrade or minimal antegrade filling of the pulmonary artery from the right ventricle. Ebstein's is a complex lesion involving tricuspid regurgitation, but the nature of the valvular malformation reduces the amount of right ventricular myocardium. So even though the right heart is dilated, there's less right ventricular myocardium to maintain forward flow, so they've got a flat pulmonary artery segment. Okay? The other class of diseases where you see a flat pulmonary artery segment are people where the pulmonary artery segment isn't on the heart border. Normally, the reason we see a pulmonary artery segment in here is because the pulmonary artery sits on the right ventricular infundibulum and is high anterior and to the patient's left. So we see a bump there. So if the pulmonary artery segment is not heart border forming, then we're not going to see a pulmonary artery segment. And we see this in detransposition of the great arteries, okay, where the pulmonary artery segment is attached to the left ventricle. It's still on the left side, it's still there, but it's posterior and not heart border forming. So in the PA view, these kids have what looks like flat or concave pulmonary artery segments. Another form of disease where you see this is in truncus arteriosus. In truncus, they don't have a pulmonary artery segment. By definition, their truncus arteriosus failed to septate into an ascending aorta and main pulmonary artery. We classify truncus by the origin of the pulmonary arteries. Truncus 1 is one big trunk from the posterior wall of the aorta, which splits. Truncus 2 is from the sides, and truncus 3 is from the posterior aspect, and truncus 4 is from the descending aorta. In none of these patients is there a main pulmonary artery segment. Okay? And finally, there's corrected transposition of the great arteries. In corrected transposition of the great arteries, the ascending aorta lies to the left of the pulmonary artery. The pulmonary artery lies to the right. Therefore, the pulmonary artery is somewhere in here, and the ascending aorta is to the left. Now, how do we differentiate these? By looking at the pulmonary vascularity. If the pulmonary vascularity is normal to decreased, it's going to be right ventricular outflow obstruction, TET pulmonary atresia VSD, double outlet ventricle, tricuspid atresia, Ebstein's malformation. These people, for one reason or another, are not maintaining their forward flow. If the blood flow is increased, then we like things like truncus or transposition of the great arteries. And if we see, good try. And if we see a big bulge on the left heart border where we don't see a pulmonary artery segment, that's corrected transposition of the great arteries. Okay? One more, I think. This one. Okay? Other routine pacemaker checkup. Watch the wires, watch catheters, okay? Look at the course of this pacemaker. What's wrong with this picture? Well, this pacemaker is only posterior. This pacemaker has not made it to the right ventricle. Okay? So how do we get from the subclavian vein to the superior vena cava to the posterior aspect of the heart? Well, if this pacemaker was put in aberrantly, let's say it went from the right atrium to the left atrium to the left ventricle. How do you get to the posterior chamber? That's where the left ventricle lives. Left ventricle is always posterior, by the way. How do you get to the left ventricle from the superior vena cava? Well, how about SVC to right atrium across the atrial septum to the left atrium to the left ventricle? Well, that's possible, but we never entered the right atrium. It's always been posterior. How about SVC to right atrium to right ventricle across a VSD to the left ventricle? Well, it never enters the right ventricle down here. This is a patient who had detransposition of the great arteries. Look at the flat pulmonary artery segment. And a mustard operation, an intraatrial baffle. So this patient had his systemic venous blood directed towards his left ventricle, which supports the pulmonary artery. Okay, blood goes out the left ventricle to the pulmonary arteries, to the pulmonary veins, to the right atrium, to the right ventricle, and out the aorta. So this is a pacemaker in the left ventricle in a patient who's had a mustard operation. Okay, we see a lot of these now because for 25 years the mustard operation was the procedure of choice for transposition of the great arteries. Transposition of the great arteries had a 95 to 98% one-year mortality prior to the mustard operation, and in the 2 decades since the operation was really started in earnest, we saw that 90% mortality go down to about a 10% mortality. So there are a lot of 20, 30, and 50-year-olds with mustard operations around here. They almost invariably have pacemakers because the mustard operation means redoing the atrial septum.
So we'll start off by talking about MRI of the foot and ankle. And I'm sort of limited with time, so I've narrowed it down to causes of marrow edema and talking about the tendons, both general anatomy and normal characteristics, and specific tendons and their pathology. So let's start off with osteomyelitis, the cause of bone marrow edema. Why do we get MRI? Well, it offers better sensitivity than conventional radiography and offers better accuracy and more precise delineation of extent than radionuclear imaging, and this is important for our surgeons and for surgical planning. The marrow abnormalities are nonspecific. You see increased signal in fat-suppressed T2-weighted images and decreased signal in T1-weighted images. If you happen to see increased signal in fat-suppressed T2-weighted images but normal T1-weighted images, usually this represents just reactive edema from adjacent inflammation, but you can never entirely exclude osteomyelitis, unfortunately. Marrow enhancement on T1-weighted fat-saturated images after gadolinium injection intravenously is also not specific. You can see enhancement of non-infected marrow in several cases, and there's really no evidence that gadolinium sequences are actually superior to non-contrast sequences for osteomyelitis detection. So why do we give intravenous gadolinium? Well, you can do it to increase the confidence of your diagnosis. It's one of the reasons why we do it. But more importantly, we do it because it's useful for depiction of soft tissue abscesses, particularly if you have a foot and there's a lot of edema and a lot of high signal on T2-weighted images. You can see on a fat-suppressed T1-weighted image after gadolinium areas that are either pus or non-viable tissue a lot better. So what are some MRI findings that can increase your specificity for saying this patient has osteomyelitis? Well, of course, if you see an adjacent soft tissue ulcer or abscess or phlegmon adjacent to marrow edema, that makes it much more specific for osteomyelitis. Or if you see frank disruption of the cortical bone related to spread of infection from a soft tissue lesion, as you see here, that of course is going to be specific for osteomyelitis. Now, one of the problems we have is osteomyelitis versus a neuropathic joint. Diabetic patients are going to be prone to both. Both are going to result in marrow edema and enhancement. Sometimes we can make a specific diagnosis of one or the other with MRI, but sometimes we can't. And this is particularly true in cases of an acutely evolving neuropathic joint where one has fractures that lead to signal intensity changes in the marrow and the cortex. And in these cases, a bone biopsy might be necessary. But there are some clues, some hints you can use. If you have adjacent soft tissue ulceration or abscesses with or without cortical disruption, as we've talked about previously, then you'll favor osteomyelitis. If the enhancement is limited to juxtaarticular soft tissues while the skin and subcutaneous tissues are relatively intact, then you might favor a neuropathic joint. Something else, if the marrow is hypointense on both T1 and T2 weighted images, in these cases favor a chronic neuropathic joint, and I'll show you an example of that in just a little bit. The other thing to remember is the real estate. Osteomyelitis tends to be a focal abnormality that's deep to an area prone to ulceration, so-called pressure points. That includes the phalanges, the metatarsal heads, the calcaneus, and the malleoli, whereas a neuropathic joint is a more regional abnormality seen around a joint or multiple joints, particularly the tarsometatarsal joint, and one may also see bone fragmentation, dislocation, and deformity, just like you see on plain films. So here's a nice MRI example of a neuropathic joint. You can see there's edema-type signal in multiple bones. This is a T2-weighted fat-suppressed image. What you don't see is most of the talus, actually. It's been almost completely destroyed, but this bone here is actually not the navicular. That's the head of the talus, which is now sitting anterior to the tibia. And notice how dark it is on this T2-weighted fat-suppressed image. And that's very typical of the findings you might have in a chronic neuropathic joint. I want to move on briefly and talk about stress fractures because we're doing MRI more and more to look for these. The first step, of course, is just going to be to get radiographs. The second step, assuming the initial radiographs are negative, well, if there's not an urgent need for an immediate diagnosis, just repeat the radiographs in 14 days. However, if there is a need for immediate diagnosis, if you're dealing with an elite athlete, then get an MRI. It's really more sensitive to conventional radiography, of course, and more specific than bone scintigraphy. There is a grading system for stress fractures, although I don't know too many people who use them, but it's important to keep this in mind that you may have edema without the actual fracture line for most of these grades. In fact, grade 1 is just simply periosteal edema without any focal bone marrow edema at all. Grade 2 is periosteal edema with marrow edema on fat-suppressed T2-weighted images. Grade 3 is periosteal edema with marrow edema on both T1 and fat-suppressed T2-weighted images. And finally, grade 4 is what we usually see, a low-signal fracture line on all sequences with marrow edema on T1-weighted images and fat-suppressed T2-weighted images. Now, I'll talk about a few stress fractures that we encounter. Most commonly, these stress fractures occur in the metatarsals, and most commonly within the metatarsals, they are in the distal diaphysis of the second or third metatarsals, the so-called march fracture of military recruits, runners, and hikers. We very rarely get MRI to look for these. Usually the clinical diagnosis is fairly straightforward, and you'll eventually see them on radiographs. Less common, however, are fractures of the base of the second metatarsal, such as you might see in ballet dancers, or the proximal diaphysis of the fifth and fourth metatarsals. And these can be more subtle, particularly those that occur in the base of the second metatarsal. On this radiograph here, you can just barely see a very vague band of sclerosis through the base of the second metatarsal, which becomes much more evident on the MRI. Here's a T1-weighted image with a low-signal fracture line with surrounding edema, and the same thing on T2-weighted image, low-signal fracture line with surrounding edema. Navicular stress fractures, we're seeing more and more of these as well. They occur in the elite athlete usually, particularly runners, gymnasts, basketball players, and linebackers, and also, interestingly, athletes that practice and play almost exclusively on artificial turf. The clinical presentation can be very vague, and radiographs may be entirely normal, and this can result in a delayed diagnosis and result in avascular necrosis, as I'll talk about in a little bit. Now, you can certainly get a bone scan to look for this. Scintigraphy will show increased uptake in the midfoot, but it can be a little bit difficult to determine exactly which bone is involved. That's where MRI comes in. You'll see the edema within the navicular, and if you're lucky, hopefully you see the actual fracture line running through the navicular. It occurs in the sagittal plane, begins at the dorsal aspect of the proximal articular surface and kind of works its way distally. And one of the complications that you have to look out for is avascular necrosis of the lateral portion of the tarsal navicular. So just as in the carpal navicular, the scaphoid, you tend to get avascular necrosis of your proximal pole. In the foot, you tend to get avascular necrosis of the lateral pole. Fibular stress fractures, also known as runner's fractures. These are frequent occurrences in runners and joggers. They occur almost always about 3 to 7 centimeters above the lateral malleolus tip, and these radiographs can be normal for up to a couple months, so every now and then we'll get an MRI to look for these fractures as well. Distal tibial stress fractures, quite common, particularly in long-distance runners, marchers, and ballet dancers, but one in particular that I want to go over is actually the medial malleolar stress fracture. We're seeing a few of these as well. These occur in runners. The fracture is going to be evident on radiographs, only about half the cases. And on MRI, you see this little vertical line right here, or oblique line with some surrounding edema. This is a T1-weighted image here. There's the T2-weighted image with that little line right there and surrounding edema. They can be very, very difficult to see on plain films unless you're specifically looking for them. There'll just be a little lucent line right there. Sesamoid stress fractures more commonly occur in the medial sesamoid than the lateral sesamoid. They can be very difficult to pick up on radiographs, so every now and then you'll get an MRI to look for these as well. You'll see edema within the sesamoid. You may or may not see the actual fracture line. There is a differential diagnosis for sesamoid bone abnormalities, which includes osteonecrosis. However, osteonecrosis more commonly occurs in the lateral sesamoid than the medial sesamoid, as well as infection and inflammation. You can just use the wastebasket term of sesamoiditis if you want to see if you see edema there. Bone contusions refer to microfractures of trabecular bone that lead to edema and hemorrhage in the marrow. One sees decreased signal intensity on T1 weighted images and increased signal intensity on T2 weighted images, and they're associated with ligamentous injuries, just as if you would have, just like in the knee, if you have medial bone contusions, you want to look for lateral collateral ligament injury. So here we have bone contusions in both the medial malleolus and the medial talus. Kissing contusions. Here's another example where we have bone contusion in the medial malleolus here, and you have a lot of hemorrhage and edema on the opposite side, and that's due to an anterior talofibular ligament disruption. This is the axial image of the same patient. Here's a normal patient here showing a normal anterior talofibular ligament. It's completely disrupted in this patient, and there's a lot of adjacent hemorrhage and edema in the soft tissues. So to review the differential diagnosis of marrow edema in the foot, think osteomyelitis if you have adjacent ulcers or abscesses or cortical disruption, a neuropathic joint if it's a joint process with fragmentation or dislocation, a fracture if you see a linear hypointensity or the clinical history is appropriate, bone contusions if you have kissing foci of edema or associated ligamentous injury, a few entities I didn't really have time to talk about, osteonecrosis if you see a serpentine pattern, most commonly in the talus. We'll talk extensively about osteonecrosis when we talk about the hip. Other more nonspecific patterns, just a reaction to adjacent inflammation without cortical disruption or altered biomechanics can cause bone marrow edema. A stress response has been talked about in the literature. This probably represents one of those early grades of stress fractures I was talking about earlier, where you actually don't see the fracture line, you just see the marrow edema. And even just following physical activity, there have been some studies that have looked at marathon runners and shown that they're prone to get marrow edema in their foot after a race, as you might imagine.